So today I'm going to do an update on diagnosis and management of what is now called Clostridioides, formerly known as Clostridium difficile infection. So I want to start by first talking about what is C. diff. So C. diff is actually a spore-forming bacteria that was recognized back in the 1970s, and it was called C. diff because it was incredibly difficult to culture. This is an organism that normally lives in your intestines, and anywhere from, depending on who you are and your comorbidities, anywhere from 3 to 50% of the population can be colonized with this organism. When you're colonized, it's a part of about 1,000 different species that live in your gut. And really, it doesn't cause disease and doesn't cause you problems. And what we're going to talk about is when it does cause disease and problems. And really, this happens when you disturb the balance of the microbiota that naturally lives in your intestines. And these imbalances can occur with antibiotic disruption, with things like manual, I can't remember the word. It'll come to me as soon as I move on. C. diff is actually on the rise, and it's becoming increasingly challenging to manage because of the increased number of cases we're seeing, and also because of hypervirulent strains that are becoming more prominent and relapses. And although it's a rare bug that lives in your gut, it's actually associated with tens and thousands of deaths and a significant amount of morbidity and mortality. There are effective antibiotics to treat C. diff, but as you will see that we commonly have relapses. 20 to 30% of patients will actually relapse with disease. So why is this important? Worldwide, there's about a 38% mortality rate associated with C. diff infection, and the annual healthcare cost is over $7 billion. But to bring it home here in the Phoenix VA, some numbers that I pulled from back in 2015, we had 182 cases of C. diff. There were 28,000 encounters associated with these 182 cases. And in our VISN, back in the day when we were still VISN 18, we had 572 cases with almost 50,000 encounters associated with this. So you can see there's a significant healthcare cost. So what is the epidemiology of infection? Carriers are individuals, you and me, up to 3% of the general population. But if you're hospitalized or in a long-term care facility, up to 50% of the population can be colonized with C. diff. And also, the next question is, well, then how is C. diff acquired? Well, it's poop. So at some point, you ate poop. It is spores that are often found in the environment. There's something actually called the fecal cloud, which is an area surrounding a patient that has diarrhea and C. diff, where these spores have a high concentration. And you at some point came into contact with those spores and you ate them. It's pretty much how you explain it. There are some rare cases of community-acquired infections that are becoming more recognized. These cases tend to be in younger, healthier individuals. Females predominate. And the recurrence rates are the same. There was a question in some studies that suggested maybe dogs could be carriers of C. diff, although that hasn't been fully substantiated. And then there was actually some meatpacking industry transmission that occurred probably 10 years ago now. So what are your risk factors? So before, this list used to be kind of simple. So it was really antibiotic exposure, age, and we used to just say gastric acid suppression, but this list has actually grown at this point. So hospital admission, of course, is where you come into contact with spores in a majority of cases, but comorbidities that include gastric acid suppression, but if cancer, GI surgeries, obesity, and also individuals with inflammatory bowel disease have a higher colonization rate and then a higher infection rate as well. So antibiotics, right? This is the main cause of C. diff. And the antibiotics that are mostly associated with this are the workhorse of antibiotics, which is really fluoroquinolones, right? It's your Cipros, your Levos, your Moxies. The antibiotics that, if you guys are here, constantly get calls from me trying to get patients off these antibiotics and onto narrower spectrum. Clindamycin and, of course, broad-spectrum antibiotics that really disrupt the normal microbiota that's within your gut. The other interesting thing is that when you put a patient on metronidazole, you actually increase their predisposition to be colonized by C. diff. You're putting on pressure, spores form, and they're more likely to colonize and to remain in your system. Vancomycin, it's actually not the IV formulation, it's the oral formulation, but again, this is because you force these organisms into the spore forms, and then they persist in the gut. And this is really also why the whole idea of pulse dosing comes from, that we'll talk about later. So what happens when you get infected with C. diff? And, you know, I forgot to say, I don't know if I said this earlier, but they renamed C. diff. It's no longer Clostridium, it's now Clostridioides. All right, so C. diff is a gram-positive organism. Normally it lives in your gut, but once you disrupt that gut microbiome and these spores are able to germinate, or you actually have an increased amount of this organism in your gut where it's able to overtake the other normal flora, it begins to produce toxins. And these toxins are what are damaging to the cell lining of the gut. So toxin A is really the toxin that we used to look for. So back when I started, geez, this sounds bad, back when I started medical school, we always tested for toxin A. It's an enterotoxin. It actually causes direct injury to the gut epithelia, and causes massive secretion and inflammation, secretion of fluids and inflammation. Now we know that toxin B is actually more important. This is the toxin we test for now. This is the one that really is the biggest culprit. So it causes cell lysis and death. It's 10 times more powerful than toxin A. It causes really significant cell injury and inflammation, and what happens is that it breaks down the lining. You get inflammatory cells, and this is how you actually will make pseudomembranes, and I'll go into that in more detail. What we know is that antibody production against toxin B in particular is protective, and there's a direct correlation between antibody response and C. diff recurrence. So there is now this NAP1 B1027 strain. It was identified in the early 2000s in an outbreak that happened in Canada. It's associated with certain antibiotic exposures. But really, what's important about this is we report it, and you're probably wondering, well, what does this mean? Well, what it means is that these individuals have lower cure rates. They have higher relapse rates, and they have increased incidence of kind of more severe outcomes and ICU stays. So the presence of this NAP1 can mean more significant disease. So C. diff is diarrhea, so you've got to have diarrhea. And I know you guys laugh at me, but I can't tell you how often I see C. diff testing canceled because people sent down formed stool. We don't test formed stool. By definition, it's diarrhea, okay? Other things associated is abdominal pain, cramping. We often see leukocytosis, and then when you actually do endoscopy, what you see are those pseudomembranes that form that are the result of the secretion and the cell death of the lining of the gut. And this is what it looks like. These kind of skipped little bumps you see all over, that's actually a pseudomembrane. So those are all inflammatory cells, dead cells, and debris. So we see relapse a lot, right? And so I'm often asked, is it relapse or is it reinfection? So what we really think is that it's relapse. It's not reinfection. Up to 25% of cases of individuals who develop primary infection will have relapse that occurs again. This can happen within days to weeks. It can happen, 2 days after they come off antibiotic therapy. It can happen 3 months later. The clinical presentation is often similar. Sometimes it can be more severe. It'll just kind of take off much faster. And as I mentioned, the recurrence rates can be as high as 80%. And it can be directly related to the viability of the immune host. As I mentioned, antibody responses are protective. So if for some reason they have an impaired immune system, their chance of relapse is much higher. So what are the complications of infection with C. diff? So one of the big things we worry about is fulminant colitis. So these people develop horrible these are sick people. They have abdominal pain, they have hypovolemia, they'll have lactic acidosis. Their leukocyte counts can reach as high as 40, 50,000. These people are sick and they need emergent evaluation by your surgical teams. And then the dreaded toxic megacolon. This is where the gut's pretty much dead. It can rupture and perforate. You'll get horrible dilatation. This is severe sepsis that occurs. And on film, And the other thing I should mention before I show you what this looks like is that these individuals can stop having diarrhea. So what happens is because of this colonic dilatation and the gut is actually dying, the stool starts pooling. There's no more peristalsis to shoot it out or push it out. So this is what it looks like. You've got severe dilatation. You've lost your haustra. It's just kind of dead tube at this point. Okay. So there are some pretty unusual presentations at this too. You can see individuals that can present with protein-losing enteropathies. They'll develop ascites, and it's rapid progression, and hypoalbuminemia can occur. I've actually seen a significant amount of post-infectious irritable bowel. So when you're evaluating patients and trying to determine, is this relapse or is it or recurrence, or is this just kind of post-infectious problems? So just think about, you know, when you see someone who's actually had a viral gastroenteritis, right? They can have persistent diarrhea for days to weeks afterwards. You've had a significant insult to the gut. C. diff is very similar. So even after you treat them, their stools may decrease, they'll feel better, but they'll tell you, you know what, I still have diarrhea, I still have loose stools. That does not equal relapse or resistance or lack of or not good treatment. What it may and most likely is that they've got this post-infectious colitis, and it's going to take time for their gut to recover. So I don't automatically jump to treating them for longer or reinitiating treatment, but I'll ask them to monitor. Is the number of stools increasing every day? Are you having associated abdominal pain? Is it associated with what you eat? And I'll often put these patients on BRAT diets. In individuals with inflammatory bowel disease, they do have a higher carriage rate. It's 8% versus the 1 to 3% in the general population. And it's actually now standard to test individuals who present with an inflammatory bowel flare for C. diff because it can be a co-founder or a cause. And then there have been some cases of extracolonic involvement. So there are several case reports of appendicitis, and then rare reports of small bowel involvement in individuals with colectomy. Now, don't go rushing out and testing your patients that have colectomy and diarrhea for C. diff. This is very rare. Discuss it with your ID doc, because often if it does go into the small bowel, it's pretty fulminant and significant morbidity or mortality with very high mortality rates, I think pushing 50%. So how do you diagnose C. diff? So I think everyone here, if you've ordered C. diff testing, you've seen that we've initiated an algorithm for you. And really the point to the algorithm is to make you think about the underlying process driving the diarrhea in your patient. So please take a history. You know, if it's chronic diarrhea, it isn't C. diff. C. diff isn't chronic, right? It's an acute illness that gets worse. You want to look for risk factors in these patients. And again, I keep saying diarrhea. Please make sure it is diarrhea. And then, you know, make sure there's no alternative explanation. A person who had just underwent colonoscopy and had, you know, cleared out their gut is probably going to have diarrhea for a couple days after. Or a surgical patient, although it should be on your differential, if they just had bowel surgery and underwent bowel cleaning for the procedure, they're probably going to have diarrhea for a few days. So think about what's happening. Those patients who are constipated and we slam them with stool softeners and they have diarrhea, that's not C. diff. That's your stool softeners. Stop the stool softeners and reassess. Okay? Diagnosis requires diarrhea and testing for C. diff. So here we still do PCR. Some facilities are doing a two-step procedure where they're looking for the presence of the organism and then the toxin. We're still doing PCR. At some point we're going to switch, and we will let you know when we do that, or the presence of endoscopic and histologic findings of pseudomembranes. And patients, such as inflammatory bowel disease patients, and those guys will often ask if the picture is cloudy, go ahead and do a quick scope and take a look in there and see if we're actually seeing pseudomembranes. And please don't send formed stools. The lab will reject it. And don't squirt saline in and shake it up, because that's not helpful. And that has happened. That has happened. I'm not making it up. All right. Okay. So this is a little bit old. We no longer do non-severe or severe. It's now just C. diff and fulminant disease. So, but I put this up here to kind of get you to think a little bit about how different presentations and when you actually need to admit somebody and when you can manage them at home. So the two big markers we look at are creatinine and white blood cell counts, okay? A number of bowel movements, I mean, if they're not able to make it to the bathroom, if they're not able to keep up with their output, then again, of course, we're going to consider admission. And then severe or complicated or fulminant C. diff is these are people where you're really worried that they're progressing to fulminant and toxic megacolon. The treatments for these two are the same. For this, it's slightly different, and we will review that. So for non-severe and severe, because I remember these are now lumped together, if you can, stop the insult. So if antibiotic is driving, if we can stop that antibiotic early, we should do that. Always call your infection control team because transmission within the hospital is a significant problem, and so we need to be able to get ahead of that. We treat people for 10 to 14 days. I hate 10, but that's what the guidelines say. I do 14. So I won't fault you for doing 10, but 14 is better. And then if you do have an underlying infection where you can't stop the antibiotics, you're going to have to continue the duration of your C. diff treatment after you stop the antibiotic, right? So usually I start that 10 to 14 day clock when that initial antibiotic insult is completed. Okay. Please don't retest stool. People stay colonized. It is not informative or helpful. You just end up landing them in isolation for longer. So if they're recovering and they're symptom-free, nursing homes will often ask you to retest. It's not appropriate. We don't do it. It doesn't actually tell you anything. So retesting in the absence of symptoms or concern for relapse is not okay. All right, treatment. All right, there's a lot here. I'm going to simplify it for you. So please note what's missing. Metronidazole is no longer used. It's off the recommendation list. You just go straight to vancomycin. For initial, again, it's 125 QID, but it's 10 to 14 days. Use 14, it's better. And then if you can't get access to vancomycin, then they say metronidazole, but we have it on our formulary here, and it's not restricted in any way. For first recurrence, you can go back and do another 14-day course of vancomycin if you want, or now it's actually recommended that you do the taper. The taper actually, what it does is it decreases the amount of vancomycin that you're exposed to. So what the thought of that is that you're pulse dosing the spores. So you put the Clostridium difficile under pressure, it'll sporulate. And so as you decrease the dosing, it allows those spores to germinate, and then you can treat it with the antibiotic. So that's the goal to the taper. Fidaxomicin is now on, is part of the first line of therapies. We prefer you to start with vancomycin. It's a significant cost difference, like thousands of dollars of cost difference. I think the last we checked, it was still about $2,800 for a 10-day course of fidaxomicin. And it does require infectious diseases or gastroenterology approval. Second recurrence, definitely you can do the taper. I do have what they've called the Blattman taper because I'll taper people for 3 months. But at this point is when we have the conversation about fecal transplant, and we'll talk about that again in just a moment. For individuals with severe disease or fulminant disease, often in these guys you'll do oral vancomycin, you'll do IV metronidazole, and depending on whether they're actually moving through their gut and how severe, you may have to do per rectal vancomycin as well. But these patients will all be inpatient by this time, and ID will be involved, hopefully. All right, what are some adjunctive therapies? So probiotic use. Data goes both ways with probiotics. There are studies that show that it's efficacious, there are studies that show it's not, and studies that say, well, we don't know, there's no difference. So for our facility, if patients are at increased risk, meaning they have comorbidities and you're concerned, then we say as long as, comorbidities and you're concerned, we say go ahead and put them on probiotic. Patients with recurrent disease, there is evidence to show that they do better if you give them probiotics, so in those patients it can be indicated. And it's Saccharomyces boulardii or Lactobacillus or Culturelle are the two that we have here available to us. For severe disease, there are monoclonal antibodies against toxin B available, and I can't ever pronounce this, bezalotoxumab. We do have this available to us, and again, these are just for people with severe disease. And then my favorite is fecal microbiota transplantation. Multiple routes. You can do it through EGD, colonoscopy. You can do it through NJ tube or rectal enema. Cure rates will range anywhere from the 80s to the 90s, depending on which route you use. And now there's a pill for that. So there are actually oral tablets you can take. It's 30 tablets that you have to swallow within a 30-minute period, and I always say, don't burp. But you do have to watch these people because they can vomit and aspirate, so that would not be good. So we always, these are done under very close monitoring conditions, and ID and GI do the transplants here, or I do the transplants here, actually, I should say. All right, recurrence. So recurrence happens from persistent spores that remain in the gut. Again, it can happen because you get a secondary insult. So somebody may be doing fine. 3, 6, 9 months later, they get another antibiotic for a sinusitis or a urinary tract infection, and they get recurrence. And again, it's because they remained colonized. It is not antibiotic resistance, and immunity, as I mentioned, is directly involved. In those that do develop good IgA responses, there's decreased incidence of recurrence. And then treatment, as I mentioned, is much the same. And as I talked about, yes, sir.
We do have a question online.
Okay.
The question is, if you're allergic to Vanco, is I'm going to try to pronounce it.
Fidaxomicin?
Yes, is that okay?
Yes, it's fine. They're not in the same category. So yeah, you can. You just need ID or GI approval. All right. So relapse, again, as I mentioned, history is really key here. Are you having more diarrhea? Are you having increased abdominal pain? So often people will persist with that diarrhea, and the key question is it increasing? So if they're having diarrhea 3 times a day and they've had it for a week, probably not relapse. But if they're having increased episodes every day or every other day, then we need to think about relapse. And it's okay to monitor with a plan in place. So often in these patients where I'm not sure, I'll send them home with vancomycin, and I say, don't start unless you have increasing, and then let me know when you do. I don't always retest them. All right, so here are your poop pills that we use in our fecal microbiota transplantation. And then this was actually recorded, and we're going to be putting it on a YouTube website so that you guys can have access to listening to it again, or if others want to refer to it, it's YouTube, and it's called Dr. Infectious. So I will take questions at this time. Oh, and real quick, we now have a third ID doc that's joined our group that many of you will actually hear from, so I want to introduce him. It's Dr. Seroy, right there. So it's no longer Dr. Gutierrez and I. Okay, so I will take questions at this time.
Really?
Yes, sir.
So after treatment you've completed, you think this may be an irritable bowel syndrome sort of situation. They're still in the hospital. Do they maintain their isolation, contact stuff until they've got warm stools?
Really good question. So different facilities do have different rules. Here at our facility, once you have C. diff during your hospital stay, you remain in isolation, regardless of what happens, just because we've had significant transmission issues here. Yes, ma'am.
So if I understand correctly, for PCR or GDH, you're testing for toxin B. Can you have C. diff with just toxin A, and how would you detect it if that's so?
Really good question. So yes, you can, but I think the evidence is really that the majority of cases are from toxin B. So we don't do, and even the EIA is looking for toxin B. It's not the 2-step GDH process is still looking for toxin B. So it would be clinical, I think, your clinical kind of gestalt. But I have to be honest, I don't think I've seen a case of C. diff in the absence of toxin B positivity in the 10 years I've done this. Have you, Justin?
No.
Yeah, doesn't happen really. Any other questions? Are there any other online?
We got one. It says, doctor, for return to work for healthy care workers, any new recommendations?
Very good question. So the question is, if you're a healthcare worker, when can you return to work? It is when you can contain your stools. No more diarrhea. Yes, ma'am.
Doctor, at the beginning of the lecture,
I'm not sure I understand your question, so.
I'm sorry, at the beginning of the lecture, you were
Right,
looking for
the
a
risk
word.
factors.
Yeah, you were saying that you would try to remember that word, and I was,
Oh, bowel prep.
yeah,
Bowel prep, yeah. I have actually seen C. diff happen in cases where people enjoy enemas. So there's this fad of coffee enemas and vitamin enemas. And I have seen a couple cases from that. Yeah. But again, it's got to be in the right clinical picture. So they had persistent diarrhea worsening afterwards. Yeah. Any other questions? All right. Thanks, everyone, for coming.